Morning, everybody. Thank you very much for the lovely welcome. I'm delighted to be here speaking on behalf of UKHSA today at the festival. My name is Greta Hayward. As said, I'm the consultant midwife at UKHSA. So that's a brand new post, actually, that's been convened because of the increasing portfolio of maternal and neonatal immunisation. So really wonderful to be here. Now, there's a lot of attitudinal studies around how trusted midwives are in pregnancy, and that's rightly so. But I do know that obviously you all have a very busy job to do, and immunisations is another part of it. There's a huge body of research, and so I can only say a few short things really in the half an hour that I've got, but so I'm not going to specifically focus on the diseases themselves, but we're going to talk about the safety aspects, the key parts of the conversations that you're going to have with women. And I have been asked to touch on measles as well, because that is quite topical. So there are lots of links throughout the presentation, which I think you receive afterwards, so do feel free to click on them. And we do have a stand downstairs if you would like to come and talk to us. So, without further ado, that is the wrong presentation on the slides I'm afraid. But whilst we're sorting that out, I will carry on. So why do we vaccinate in pregnancy? So we vaccinate to prevent maternal morbidity, thank you very much, and mortality, to prevent poor pregnancy outcomes and fetal outcomes, and to confer passive immunity to prevent disease during infancy. So we vaccinate to make sure mother and baby are safe throughout the pregnancy. It's one of the most effective interventions that midwives and other healthcare practitioners can provide to reduce harm from vaccine-preventable diseases such as flu, COVID-19 and pertussis, which is whooping cough, for mums and babies. So we do know that if you're preventing maternal mortality and morbidity, pregnant women have an increased risk of severe disease from some of the pathogens during pregnancy, particularly due to the cardiorespiratory changes that they have. We can prevent poor pregnancy outcomes such as miscarriage, premature delivery, low birth weight and congenital abnormalities. And as I say, we have this, neonates and young infants are susceptible because their immune system is still developing. So the transplacental transfer of maternal antibodies is an important source of interim protection. So, what are the current vaccine recommendations in pregnancy? I'm sure you all know this, so I'll skip through it quite quickly. And as I say, they are to ensure the protection of the pregnant woman, the unborn baby, and the infant in the first few months of life. There are additional vaccinations that aren't on here, such as MMR status of all women, so it's important for midwives to refer any unvaccinated or partially vaccinated women to their GP to catch up after they deliver, because you can't give MMR as a live vaccine in pregnancy. So flu is given every year during the flu season from the 1st of September, and women should be offered this at any time in their pregnancy, in the flu season, and in every single pregnancy. Pertussis or whooping cough is usually offered around 20 weeks, ideally between 20 and 32 weeks. It can be given from 16 weeks gestation, but it's normally given alongside the fetal anomaly scan. I'll talk a bit more about that later. And then COVID-19 is when it's recommended by JCVI, and we are waiting on a policy decision for that for the autumn programme. So, let's talk a bit more about flu. So, as I've said, the impact of flu infection in pregnancy increases, and we're obviously concerned about having flu in pregnancy because it can be quite devastating. So there are cardiovascular changes that you know about in pregnancy, and these can lead to severe disease, hospitalisation, including ICU admission, and particularly in late pregnancy when we know there are a decreased lung capacity and tidal volume in mums, increased oxygen consumption as a result of the baby, and a suppression of T-cell activity. And all of those things mean that women are at higher risk of having some maternal mortality during pregnancy. There are also other associated factors such as obesity and diabetes, which can lead to higher mortality. So in the last triennium report, the Embrace report, 2 women did die from having flu in pregnancy, and neither woman had received the flu vaccination during their pregnancy. We also know that if you have flu in pregnancy, it can lead to poor pregnancy outcomes such as miscarriage, premature labour and low birth weight, and that children under 6 months have the highest rate of GP consultations and hospitalisation for flu in the UK. So vaccinating mum in pregnancy helps to protect newborn babies. So one of the things that we're often asked about is the effectiveness and safety of vaccinations. So we do know that flu vaccination is incredibly effective. Vaccination halves the risk of infection compared with confirmed flu in pregnant women. It reduces the risk of prematurity by 72% during the period of widespread flu activity, which is obviously in the winter months in our hemisphere, and also reduces low gestational weight by 69%. We know it provides passive neonatal immunity for the first few months of life and a 63% lower risk of lab-confirmed influenza among infants. So we can see from all this that it is a very, very effective vaccine. Now, in terms of safety, I know there's always a real issue around safety. I'm a midwife myself, and when I was first practicing, which was some time ago now, obviously we didn't give vaccinations in pregnancy. So I know that it's a question that you're asked quite frequently and something that you need to be able to answer. So there have been an awful lot of studies around all the vaccinations. And you can see here from this top study, which was done in 2009, which is obviously some time ago, it concluded that no study to date has demonstrated an increased risk that either maternal complications or any untoward fetal outcomes associated with the flu vaccination. So that was quite a while ago, but a more recent study of over 100,000 pregnancies, which is a large study, confirmed the safety of the vaccine and said again it wasn't associated with any risks. So let's have a look at the flu vaccine uptake in pregnancy in England, and this is the latest published data that you're seeing on the screen, published at the end of May 2024. And if you look at the grid that's on the screen, you can see that we are starting to see a real decrease in uptake, and in fact for the past 6 seasons the uptake of flu vaccination in pregnancy has fallen. So we know the flu season is between September and March every year. The pregnant women having flu vaccination was added to the national programme in 2010 to 11. The highest end of season uptake on record was during 2017 and 18, which is the top of the slide here, and you can see that 47.2% of women took up the vaccine. But we also know that vaccine uptake in all pregnant women, healthy and at-risk groups combined, was 32.1% in the last season, 23 to 24. So you can see that even from last year, that is a decrease of 2.9 percentage points from 2022-23, and is in fact, as you can see, the lowest end of season uptake on record, 2011-12. So let's move on to pertussis, which is whooping cough vaccination. So whooping cough is an extremely serious disease in babies, and it can lead to complications which result in hospitalisation and even death. And infants are the most vulnerable group, and almost all deaths from pertussis occur in this age group, with the most occurring in those that are younger than 3 months of age. So what we do is we vaccinate mums to boost the antibodies in mums, to pass through the placenta, transplacenta boost to babies, and it helps protect the babies until they're able to get their primary vaccines, which start at 8 weeks, 8, 12 and 16 weeks. And so clearly the most important thing is to protect the baby until they can have their primary vaccinations, and we do that by offering a maternal vaccination programme. As I said, pertussis severely affects infants and young children, and they are more likely to develop severe complications. And as you can imagine, in these very young babies, it's not a pleasant picture to be able to see babies who are having seizures or who can't breathe or have difficulty breathing. 90% of these infants do require hospital treatment. And as I say, there were 8 infant deaths have been recorded this year, which I'll come on to. So I thought it would be useful to show you this graph, which is laboratory confirmed cases of pertussis by quarter in England from 2011 to 2024. So pertussis is a cyclical disease. You'll see a peak every 3 to 5 years, which you can clearly see on the graph. And the last cyclical increase occurred in 2016, which is in the centre of that graph and is quite a small sort of peak. As well as being cyclical, there are seasonal peaks, with most activity occurring in the 3rd quarter of every year. One exception to this was in the year 2011 going into 2012. And we're seeing an increase in quarter 3 every year. And that was very similar to what's going on now in 2023 going into 2024. So you can also see on this graph that we haven't had any pertussis activity in the last 2 to 3 years, and that was mainly following the introduction of the control measures put in place for COVID-19. So we weren't particularly expecting to see any pertussis during that time. The expectation, because it's a cyclical disease, is that pertussis would re-emerge, and it's actually taken slightly longer than we thought it was going to do, but it has come back, and you can see on the graph on the right-hand side that it is a large peak at the moment. So this is onset laboratory confirmed pertussis cases in England, and you can see on the graph here on the left-hand side, the cases are very much skewed to the left-hand side of the graph, and these are the infants that are too young to be immunised, and that's where most of the cases occur. And this was the picture before we introduced maternal vaccination, and as you can see, as the maternal vaccination was introduced, cases did decrease. And it's clear that a high proportion of infant cases occurred before they received their first dose of vaccine at 8 weeks. Now, infants need to receive vaccine at 8, 12 and 16 weeks in a timely manner in order to gain maximum protection from the programme. So the graph shows the age at the onset of pertussis by weeks of age in infants up to a year based on lab data. We know that infants in England are immunised in a timely manner, but the graph clearly shows that the majority of cases occurred in the first few weeks of life before they could be protected by their own primary vaccinations. So this is a graph showing laboratory confirmed cases of whooping cough by month in England from 2018 to April 2024. You can see on the graph the bars are the current year and the lines are the previous year. So the dotted line is 2023, and we can see that activity started increasing in December 2023, really, and by any standards, you can see that there is an increase in the first 3 months of 2024, which are the bars, and that confirms the high levels of activity of pertussis in the population currently. So the latest data in June 2024 in England, provisionally there were 4,793 confirmed cases of whooping cough reported to the UK HSA between January and April 2024, so in those first few months of 2024. And that compares with 858 provisional samples, confirmed cases reported in 2023. So a huge increase in whooping cough activity that's currently being seen. And there have been 80 reported deaths in infants who developed pertussis between January and April 24. And some of these infants are, very young in age. I think the youngest died at around a week and a half of age, so it is extremely concerning. So this is the graph showing infant deaths in the 12 years prior to the introduction of maternal vaccination in October 2012. So maternal vaccination was introduced in 2012, and you can see that big peak on the graph. And prior to that, 63 deaths had occurred in babies under 1 with confirmed pertussis. In 2012, during the last outbreak period, infant cases resulted in more deaths in babies than had been seen in the last 20 years, and 14 babies died in that outbreak with confirmed pertussis. They were all under 10 weeks old at disease onset, and none of them, they were all too young to have had their own primaries, but none of them had received any vaccine doses. And as I say, that's when the maternal programme was introduced. And you can see on the right-hand side of the graph that did have a big impact in deaths. However, unfortunately, we have continued to see some deaths in infants with pertussis since the introduction of the vaccine. And from 2013 to the end of March 24, there have been 26 deaths in babies with confirmed pertussis, all of whom were too young to be vaccinated by their own primaries. And as I said, sadly, this includes 8 deaths in infants who've contracted pertussis in the first quarter of this year. And so that basically further underlines the importance of ensuring that all pregnant women are given the opportunity to protect their babies from birth against pertussis through timely vaccination in pregnancy. We know the vaccination has 97% protection against the disease and 92% protection against death. So people do ask, obviously, about the safety of the vaccines. It's extensively monitored by MHRA, and they found no evidence of any increased risk of the vaccination. Something that for you to note, at the moment, we use Boostrix in the pregnancy for pregnant women, but the vaccine is due to change on the 1st of July of this year, so very soon, in the next couple of weeks, we're switching from Boostrix to Adacel. So I don't know if you've heard about this or not, but from the 1st of July, the vaccine to be used in the programme is Adacel. And the reason for that is JCVI looked at all the data, this very large study here, the IMAP study that you can see on the screen, and they found that there was a lower antibody response to the polio antigen in infants with vaccinated mothers at age 13 months and in young children of vaccinated mothers before and after the preschool booster. It's what we call a blunting effect. So all of those babies did meet the protective threshold, so there was no evidence that it's clinically significant, but we do try to use as few antigens as possible in the vaccines, and so we're swapping from a vaccine that did contain polio to one that now doesn't contain it, and as I said, that starts on the 1st of July. Now, I've talked to you quite a lot about the increase in cases, and offset against the increase in cases is also this rather worrying slide around pertussis vaccine uptake in pregnancy. So on the slide, this is the latest data updated on the 4th of April 2024. The light blue line right at the bottom is the maternal vaccination uptake rate for 2023. So you can see that it's fallen significantly, and in fact maternal vaccination uptake for pertussis fell from over 70% in September 2017 to around 58% in September 2023. And of course it is of a great concern set against the data on the previous slides looking at infant mortality from pertussis infection in children born to unvaccinated mothers. So we know there are some limitations with the data and the way the data is recorded and passed from maternity units through to the GP practice. So we're looking at doing some work around trying to record the vaccination in a more timely manner. So I'm not going to spend too long talking about COVID-19 because, as I said, we're waiting on a JCVI recommendation as to whether this will be in the autumn programme or not. I've put the Embrace report up here from the last triennium, and you can see from that so this was 2020 to 2021, which obviously covered the lockdown period, and 45 women did die during this period from COVID-19 pneumonitis. 27 of those women were eligible and could have received 2 doses of vaccine. Some were documented as having received pertussis or flu vaccination, but there was no documentation whether they'd even been discussed about the COVID vaccine. One of the things that came out of the Embrace report was that at the time some of the messaging perhaps hadn't been as clear as it should have been, and that women had maybe been excluded from the research. So there were 3 basic messages from that report. Said not to exclude women inappropriately from vaccine research, make sure the messaging for vaccines is clear and well informed, and have a rapid process for rolling out information to healthcare practitioners around new vaccinations. There is a lot of research now around the COVID-19 vaccination. Many of the links are on here, and you can see that the effectiveness of the COVID vaccine in pregnancy was 54% lower risk of the infection, 27% lower risk of intrauterine fetal death, and 12% lower risk of NICU admission. And there's some studies here around the safety of the vaccination in pregnancy. This is the COVID-19 vaccine coverage, which you can see on the screen now. The data in blue is the 2023-24, and again you can see that it's the same picture as for the other vaccines that I've talked about. Uptake is falling across the board. But we know that the vaccination is the safest and most effective way for women to protect themselves and their pregnancies against severe COVID-19 disease. So, moving on. So I don't know how many of you have heard about the new programme for respiratory syncytial virus that is going to be introduced from the 1st of September. As I said previously, there are an increased number of vaccinations in the maternal and neonatal programme, and this is one of them. So you probably have heard quite a bit about it. It is another winter respiratory disease like flu. It affects around 90% of children under 2 years of age, usually with mild cold-like symptoms, but it can cause severe disease such as bronchiolitis in infants, especially very young infants or those born prematurely who have predisposing conditions such as lung or heart disease. Bronchiolitis is a common cause of hospitalisation in children under 1 year of age, and it required RSV-infected children require hospitalisation, and there were 33,500 hospitalisations annually in children aged under 5 years of age. So it's a significant impact. In high-risk children, the mortality rate is around 3%, and there are 20 to 30 deaths per year in the UK. So in 2023, JCVI reviewed the evidence around a vaccination programme for RSV and concluded that there were possibly going to be 2 options that would be viable. One was using a maternal vaccination, and the second was to use what we call a monoclonal antibody for infants. And we've been waiting on a policy decision which actually has just been reached. So I can tell you that we are going to have a maternal vaccination programme for RSV to protect infants. So the vaccine that we'll be using for that is called Preventable, and it will be offered around the 28-week time of gestation of pregnancy. You can offer it between 28 and 32 weeks of pregnancy, but obviously the time period for offering the vaccine is shorter because you can't give it until 28 weeks. So we're saying that as soon as people turn 28 weeks, if possible, they should be offered the vaccination. We are at the moment in the process of writing a PGD and supporting documentation, which hopefully will be available quite soon. I'm just very quickly going to whip through measles because I can see I haven't got much time left. You probably all know about an increase in measles. There's been a rise in measles cases globally, not just in the UK. We have had an outbreak in the West Midlands, and there is increasing activity in London, and it's predominantly affecting our under-vaccinated populations. Vaccine uptake rates fell globally during the pandemic, and in the UK, MMR coverage has fallen to its lowest in a decade. MMR is a live vaccine, can't be given in pregnancy, but what we do say is if you can ask women when they come to see you whether they have had their 2 vaccines, MMR vaccines, and if they haven't, if you could signpost them to the GP for when they've delivered their baby to have the vaccination. So what I did want to point out to you are some of the resources that we have available. So many of you have come to this, I can see lots of you that I've already seen this morning, and many of you have come to the stand this morning to talk to us about resources. But just wanted to point out to you that we do have a website which has both patient-facing leaflets in many languages, including British Sign Language, and there are QR codes that you can access. But we also have a wealth of resources available for healthcare practitioners, and they answer lots of questions that you might have that you didn't know who you could ask, basically. So things like, can I give this vaccine with anti-D? Can this vaccine be given when you're breastfeeding? Those sorts of things. So please do use the links and the resources that are in the presentation. And if you've got any questions, we'd love to see you on the stand this afternoon. I think that's it. Thank you. Anyone got any questions they'd like to ask?
I just wondered, I'm guessing the pertussis and the RSV vaccine can't be given combined. There'll be 2 separate vaccines, will they?
So that's an interesting question. So pertussis should be given around the 20-week gestation mark, and RSV will be later at 28 weeks. So technically they should be separated. Now, if you've got somebody who turns up for a vaccination and they've missed their pertussis vaccine and you don't think they're coming back, then you can actually co-administrate it. It is better if there's a 7-day gap between them, but if you think that the woman is actually going to not come back again, then better to vaccinate that than not. All of that sort of information will be in the healthcare practitioner's guidance and in the Green Book as well. So if you're seeking answers around those sorts of things, then please do, when we've published it, look at the healthcare practitioner's guidance, because you will be able to find answers to those sorts of things in there.
Thank you very much.
Thank you.